Okay, this is chapter 22, and what we're going to be dealing with here is the urinary system. Um, why do we need a urinary system? Well, remember from the metabolism chapter that one of the byproducts of the food that we eat, particularly the proteins, is the toxic compound ammonia. And if this builds up too high in the tissue fluids or in the plasma, what can happen is that we can send the body into azotemia or uremia, and that could end up killing you. So it's important that the body be able to dispose of these toxic compounds as quickly as they are produced. And this is one of the primary roles of the urinary system, which is to dispose of liquid waste. Now, there are other important roles for the urinary system. There's the regulation of plasma ion concentration, the regulation of body water, and what this does is control blood pressure as a result, the regulation of blood pH, and as a result interstitial fluid pH, the production of certain hormones, and the excretion, of course, of liquid waste. It's comprised of two kidneys, one on the right and one on the left. They're on the posterior body wall, and ureters, which are tubes that lead from the kidneys and carry the urine down into the bladder, which is enclosed in the pelvic girdle. And here is a peek at the urinary system. And so you can see here your two kidneys along the posterior abdominal pelvic wall. And one of the things that you'll notice is that they lie beneath the liver, and they lie beneath the end of the rib cage. And that's significant because a blow to the lower back could very easily dislodge one of these kidneys. And if that occurs, we could potentially block the route of urine production from the kidneys to the bladder, and that could end up being a medical emergency. There's only connective tissue holding the kidneys in place against the posterior body wall. There's no bony protection to speak of, and so this is an extra special precaution. If you're a boxing fan like I am, one of the things that you may have noticed is that boxers wear extremely thick belts around the midsection, and one of the reasons for that is to protect the kidneys. It's also forbidden for a boxer to take a kidney punch, which is a blow to the lower back, and it's for exactly these particular reasons. Now, here you can see the ureters. Okay, there is the urinary bladder, and then the tube that leads from the urinary bladder to the external opening is the urethra. Okay, so urine is produced in the kidneys. It is then sent down the ureters. From the ureters we enter the bladder, and then from the bladder we exit the body through the urethra, and then that's the end of the trip. Notice also that the left kidney here is higher than the right, and that's to make room for the liver. And also notice that on the top of each kidney are the adrenal glands. Remember them as part of the endocrine system. They produce the hormones aldosterone, cortisol, and androgens in the cortex, and adrenaline in the medulla. Okay, the kidney is itself divided into a cortex and a medulla. Remember that cortex is just anatomical terminology for outer covering. The medulla is the inner portion, and it contains structures called renal pyramids, and in between these renal pyramids are structures called renal columns. The urine is produced in the kidney, and it enters the renal pelvis, which is essentially a chamber that is near the indentation of the kidney. And from there, the renal pelvis empties into the ureter, and then from there to the bladder. Okay, so long story short, the process of producing urine actually begins in the cortex, enters the medulla, enters the renal pelvis, and then comes out the ureter, from there to the bladder, and from there to the urethra. So let's take a peek at some of the structures of the kidney. And there you can see the outer cortex shown here. Okay, this light colored area. This part that lies superficial to the cortex is called the capsule, and it's made up of connective tissue. The renal columns are these layers of white tissue in between each of the pyramids here. And the renal pyramids themselves are these things that I'm tracing now. Okay? And we'll talk in a minute about why these structures are important. This area here that begins with the base of the renal pyramids and it ends at the apex of the renal pyramids, this is termed the medulla of the kidney. So again, this is the inner portion, and of course this is the cortex, as we previously mentioned. Now, as urine is produced, it empties through the papilla of the renal pyramids. These are these tiny projections here that look like almost like little finger-like protrusions into these sort of flanged areas. And the papilla contain a lot of holes in their tips, sort of look like a salt shaker almost, and it's through these holes that the urine enters now the minor calyces, these little flanged areas. There's a minor calyx, there's one, there's one, there's one, and so forth. From there, the minor calyces empty the urine into the major calyx, then to the renal pelvis, and then from the renal pelvis down into the ureter, and then from there to the bladder, and then from there to the urethra again. About a quarter of your resting cardiac output goes through the kidneys at any moment in time. The left and right renal arteries carry the initial blood supply to the kidney. These then branch into the segmental arteries, which then branch into the interlobar arteries. Those branch to the arcuate arteries and then to the interlobular arteries. And from there we head to the afferent arterioles, which enter the glomerulus. And we'll see a picture of what all this looks like in a moment. From the glomerulus, we enter the efferent arterioles, which then enter the peritubular capillaries. And then this leads to the peritubular veins, which ultimately lead back to the renal vein, and this drains the now cleaned blood back into the venous system. Capillaris units are the nephrons that are grouped at each of the pyramids. So let's take a peek here at, again, the kidney. Okay, let's look at the renal blood supply very closely. This is the renal artery. All right, now, as the renal artery enters the kidney, what happens is it branches off into segmental arteries. There's a segmental artery. There's a segmental artery. From there, we branch into what are called interlobar arteries. That is an interlobar artery. That's one, and that's one. Okay, these guys that run up in between the pyramids, so they're basically in the columns, in the renal columns. Then as we take a sharp turn around the base of the pyramid, we go from being a interlobar artery to an arcuate artery. Arcuate means to arch or branch. Off of these arcuate arteries are the interlobular arteries, these very tiny arteries that are projecting into the superficial aspect of the renal cortex. Now, to see where the blood goes next, we have to shrink ourselves down and become little micronauts so that we can see what the branches off the interlobular arteries feed. And what we see is that the afferent arteriole is the branch off the interlobular artery that enters now the glomerulus, this cluster of capillaries that's contained inside a structure called Bowman's capsule. From there, the blood leaves through the efferent arteriole, where it enters the peritubular capillaries. They're called peritubular because they surround the renal tubule. And so you can see them all in close proximity to the renal tubule. There's a very close association between renal blood flow and the renal tubules because there is a lot of transport of material in and out of the tubule and in and out of the capillary blood that surrounds it. So we don't want to have to go a great distance in order to achieve those goals. All right. This is just a list showing you how the renal blood flows into the kidney, then is cleaned by the kidney, and then exits the kidney. Okay, so you can probably see this better in your book, so you might want to refer to the chart that indicates renal blood supply, but it follows the path that we basically described for you. Let's just take the path out of the kidney for fun. Once the efferent arteriole reaches the peritubular capillaries, it enters the interlobular veins, which are the venous counterpart to the interlobular arteries. and from there we hit the arcuate veins, from there to the interlobar veins, and from there we empty directly into the renal veins. The only real difference between the arteries and the veins in the circulation of the kidney is that there are no segmental veins. No segmental veins. Now we're going to discuss the functional unit of the kidney, and that's the nephron. Nephron is where the blood cleaning actually happens. It's a unit of renal function. It's made up of a corpuscle and a tubule. The corpuscle forms the filtrate, and the glomerulus and the glomerulocapsule are found in the cortex of the kidney. The proximal convoluted tubule branches off Bowman's capsule, and from there it heads into the descending limb of the loop of Henle, which drops down into the medulla of the kidney. And from there we take a U-turn and we head into the ascending limb of the loop of Henle, which then exits the medulla and goes back to the cortex, where it enters the distal convoluted tubule. And from there, the distal convoluted tubule will empty in the cortex into the collecting duct, and then the final filtrate, as it goes down the collecting duct, will actually now be deemed full-fledged urine. Once we head down through the medulla one final time, we enter the minor calyx. From there we enter the major calyx. From the major calyx we enter the renal pelvis, and from there we enter the ureter, and we know what the rest of the trip is. So this is just a look at the anatomy of the nephron. And so what we've done here is we've taken the junction between where the base of the renal pyramids are and where the cortex is, and we're showing you what's called a cortical neuron, or a nephron. And the reason it's called a cortical nephron is because a significant portion of it lies in the renal cortex. The other types of nephrons that are also important are called juxtamedullary nephrons, and they're named that way because the majority of their structure lies in the renal medulla. Now, if you look very carefully here, what you're going to see is the Bowman's capsule. Okay, in the Bowman's capsule, what happens is that we capture blood filtrate, which is produced as a result of the combined colloid and hydrostatic pressure inside the blood in these capillaries, and that forces fluid out of the blood and into this little capsule. From here, we head into the first wiggly part of the nephron, and that's called the proximal convoluted tubule, or PCT. Say it again with me. PCT, proximal convoluted tubule. Well, what the heck does proximal mean? It means near the Bowman's capsule, all right, and as a result, near the glomerulus. They then enter the descending limb of the loop of Henle, meaning what? Meaning that the filtrate heads down into the medulla, that hence descending. All right. Next, what happens is that we make a U-turn here. All right. This is the loop in the loop of Henle, and now we head into the ascending limb of the loop of Henle, out of the medulla towards the cortex, and then we enter the last wrinkly part of the nephron. This is the distal convoluted tubule, which then empties into the collecting duct, and then the collecting duct sends the urine back down through the medulla of the kidney one last time, where it exits at the tip of the renal pyramid through these little perforations. Okay, this is where the urine comes out, and now we're in the minor calyx, ready to enter the major calyx, the renal pelvis, and then from there the ureter. Okay, so this again is another nice diagram that's also present in your book, okay, in chapter 28. All right, so how does this filtration unit work? Well, for one thing, let's remember that there's millions of them in each kidney. The reason that's important is because it means that the kidney does a lot of work in a very tiny physical space. Your average kidney is about the size of a bar of soap, and it cleans all your blood every day. That's an amazing feat. What happens at the glomerulus is that the combined hydrostatic and osmotic pressure force the plasma through tiny slits that are around the glomerulus, and as a result, the only stuff that enters the filtrate, which is produced here, is stuff that's smaller than the size of the smallest slits in this particular region. Next thing that happens is the filtrate passes through the Bowman's capsule into the proximal convoluted tubule, which is going to lead away from the glomerulus and the Bowman's. In this region, in the proximal convoluted tubule, we do a lot of reabsorbing. Reabsorbing of what, you might ask? Well, stuff that we need to keep. What are some examples of stuff we need to keep that could be in this plasma filtrate? Well, fuel, all right? And when I say fuel, I mean carbs and proteins and fatty acids and glycerol and so forth. We also reabsorb a lot of water, which the body needs in order to maintain normal fluid balance. And we also reabsorb a lot of electrolytes. Okay, so we pick up a lot of stuff that we want to hold on to in this first portion of the nephron, the PCT. Next thing that occurs is we leave the PCT and we enter the loop of Henle, where secretion goes on. And what is secretion? Secretion is the placing of components in the blood into now the filtrate. So what happens here is that we're sucking toxins out of the surrounding tissue and we're putting them into the filtrate, which will eventually be the urine. So they secrete some materials into the filtrate, and then once we've done that, once we've secreted the toxic compounds we want to get rid of, the rest leaves the body as urine. That is your liquid waste right there. And it's just showing you the nephron sort of stretched out. So in the first portion of the nephron, we have filtration from high blood plasma into the nephron. The next thing that happens is tubular reabsorption from the fluid into the blood, which happens primarily in the proximal convoluted tubule. And we have tubular secretion from the blood into the fluid. And then at that point, the urine can exit the functional unit, can enter the minor calyx on its way through the collecting duct, and then we run out the body. There's two layers of glomerulus that surround, or two layers of capsule that surround the glomerulus. There is a visceral and a parietal layer. Okay, the visceral layer is closest to the glomerulus. The parietal is furthest away from the glomerulus. And again, this is inside Bowman's capsule. Between this area is what's called the capsular space, and that's where the filtrate is actually first produced. It's where it first appears. Podocytes, podocyte stands for foot cell. And the reason they're called podocytes is because these cells look like they have little fake feet. Not human feet, but feet like you might see on a bug that wrap around these glomerular capillaries. And they support the capillary epithelium. They help form the filtration membrane, and they're permeable to water and solutes, but not most proteins and blood cells. And this is what accounts for the colloid osmotic pressure, the net colloid osmotic pressure being into the bloodstream instead of out of the bloodstream. So what tips the balance in the kidney towards the production of filtrate as opposed to stop making urine, kidney failure, is the pumping action of the heart. Okay, if the heart were to slow its beat sufficiently or to stop, we would quit making urine, and we quit making filtrate, and the toxins would build up in our blood and our tissues, and we'd end up dying. Okay. Now, filtration pressure. There is blood pressure that's necessary for filtration. The pumping action of the ventricles of the heart are what supply this. It's opposed by the colloid osmotic pressure, which is in the opposite direction, back into the bloodstream at the level of the glomerulus, that little cluster of capillaries that sits inside Bowman's capsule. We can adjust the efferent and efferent arterial diameters to control the pressure inside the glomerulus. Even with small changes in blood pressure, we can manage to keep a relatively static amount of pressure in the glomerulus, and as a result, continue to make urine. In the event that we have such a dramatic drop in blood pressure that this trick won't work, what happens then is we go into kidney failure. Now, the muscles that do this are smooth muscle, and what they do is they can open the incoming door and close the outgoing door as the body sees fit. If we want to increase the rate at which we produce urine, what we could do is open the diameter of the afferent arteriole and decrease the diameter of the efferent arteriole. And what that does is that increases glomerular pressure, which increases something that we call glomerular filtration rate, or GFR. And that results now in a restoring of the body fluid levels to its homeostatic state. On the flip side, if we want to reduce the glomerular filtration rate, what we do is we close the afferent arteriole, we vasoconstrict it, and then we open the efferent arteriole, and what that does is it drops glomerular pressure, and then it decreases glomerular filtration rate. So, how about this rate? It's usually between 105 and 125 milliliters per minute. That's a lot. It determines the net reabsorption because it can determine the flow of filtrate. A hormone called atrial natriuretic peptide, which is produced, guess where? In the atria, has the action of increasing glomerular filtration rate, and it responds to increased blood volume. Sympathetic stimulation also can control GFR by promoting vasoconstriction and decreasing net GFR. We can also alter urine production, and this will have an effect on glomerular filtration rate. The higher the GFR, the more urine is produced. The lower the GFR, the less urine is produced. And so what you're looking at here are the hemodynamics of the glomerulus. So take a peek at that for a minute. Now what do you see? Well, this is the incoming arteriole. This is the afferent arteriole. This is the glomerulus, this cluster of capillaries. And this is the net movement of filtrate out of the glomerulus and into the capsular space. So what we're doing here is we're cleaning the blood. Now, what happens after the blood's been cleaned, after it's passed through this little hydrostatic filtration structure? It leaves the glomerulus through the efferent arteriole. But notice something about the afferent and the efferent arterioles. The ascending limb of the loop of Henle is very close by, very nearby. And that's by design. What happens when the osmotic concentration of the blood that's in these afferent and efferent arterioles changes is that this will be sensed here by specialized cells that surround this ascending limb. Okay, this is called the juxtaglomerular apparatus, and what it does is it senses the chemistry of the filtrate in the tubule and the chemistry of the blood, and it makes adjustments so that the glomerular filtration rate can compensate for changes in total body fluid. For instance, if the body were in need of fluid, it would slow the GFR down. If the body didn't need as much fluid, it would speed the GFR up. And we can do that by, again, controlling the diameters of these incoming and outgoing vessels. Okay? And also, in general, controlling the production of hormones that govern fluid balance, one of the most important being angiotensin. Okay. Tubular reabsorption occurs in the proximal tubule of the nephron. About 65% of the sodium in the water are reabsorbed in this area. And how does this work? Well, the sodium is reabsorbed first and the water follows it. Remember that water chases solutes. Normally, we reclaim 100% of the nutrients in the PCT and about 100% of the bicarbonate, depending on blood pH. We also engage in active transport of certain solutes across the membrane of the proximal convoluted tubule. Osmosis then moves the water to the appropriate side of the renal tubule, either into the filtrate or out of the filtrate, depending. And then the cells distal to the proximal convoluted tubule fine-tune the reabsorption until we now have an appropriate fluid and electrolyte balance. Tubular secretion takes place along the entire length of the renal tubule. Major substances include hydrogen cations, potassium cations, ammonia, and urea. All things that we either want to get rid of or we want to very tightly control. It helps regulate the plasma pH, keeping it between 7.35 and 7.45. If your diet is acid, if you consume a lot of acidic foodstuffs like citrus fruits and so forth, your urine will become acidic in an effort to try and keep your body's pH within a nice homeostatic limit. If this didn't occur, if the kidneys were unable to compensate this way, what would happen is that as you ate foodstuffs that were at a low pH, your body tissues would assume a low pH, and again, this would be a disaster for the human body. You eventually would have the chemical reactions that govern life shut down because you change membrane potential, you denature proteins, and so forth. Okay, how does the urine, where's the urine made and where does it go? Well, it runs from the collecting ducts to the minor calyces to the major calyces. It runs from the calyces then to the ureter, and then from the ureter to the bladder, and then from the bladder to the urethra. And what you're looking at here is just a list of the different components that are either secreted or reabsorbed in different parts of the nephron. Okay, so we go from, again, the glomerulus inside Bowman's capsule to the PCT, to the descending limb of the loop of Henle, to the loop itself, to the ascending limb of the loop of Henle, to the distal convoluted tubule, and then to the collecting duct here. Now, just for a quick frame of reference, why do you think so many different things happen in different parts of the nephron? It's just a tube, right? It goes from point A to point B. So why is it that one part of the tube does a lot of sodium excretion, another part of the tube does not? And the reason for that is that this tube is not made uniformly of the same tissue all along its length. It's actually a composite of different tissue types stitched together, which perform different activities in different parts of the cell. Okay. One of the ways that we control fluid balance is through the renin-angiotensin system. So angiotensin and aldosterone are major components of this system. Angiotensin 2 has as its net effect the elevation of blood pressure and the resulting increase of filtration rate. And aldosterone is our sodium retainer. Allows us to hold on to dietary sodium by recovering it from the filtrate, and this results in a concomitant recovery of water because, again, the water is going to follow the solutes wherever they go. Angiotensin 2 stimulates sodium chloride resorption in the proximal tube, and this results in an increase in water influx into the body. Aldosterone increases sodium reabsorption and potassium secretion in the distal convoluted tubule and also in the collecting duct. The more ions are reabsorbed, the more water is absorbed back into the body, again, because the water is going to chase the solutes. Atrionatriuretic peptide has the opposite effect of angiotensin 2 and aldosterone. It decreases blood pressure. It does this by increasing glomerular filtration rate and inhibiting aldosterone action, which leads to less sodium being reabsorbed and, as a result, more fluid leaving the body. ADH, which stands for antidiuretic hormone, responds to increased concentrations of solute in the blood and drops in blood pressure, and what it does is it acts to elevate blood volume and blood pressure by allowing us to hold on to more of our body water, and as a result now we restore blood volume, restoring blood pressure, and keeping us within homeostatic limits. ADH is vital for water balance. Increased concentration of solutes in the blood plus a fall in blood pressure results in an elevation of ADH. Without ADH, the distal convoluted tubule and the collecting duct walls are relatively impermeable to water, and we produce, as a result, dilute urine. Why is that? Well, because on that final trip through the collecting duct, if the collecting duct is permeable to water, what happens is that as the urine passes through the medulla, water will leave the urine and the urine will become very concentrated, have very little water and a whole lot of dissolved solutes. Now, with ADH, water reabsorption occurs at a significant level, and this results in concentrated urine. Why? Because we are pulling fluid out of the urine and placing it back into the body cavities, right? Or into the interstitial fluid and into the general circulation as well. You should make about 1.5 liters of urine daily. 95% of it will be water. There will also be urea, creatine, potassium, ammonia, uric acid, sodium, chloride, magnesium, sulfate, phosphate, and calcium in this urine that you produce. The composition of urine depends on your diet and your state of health. And what you're looking at here is a chart detailing the regulation of water absorption. So let's just do an example. Okay, let's say that you are dehydrated. You really need a drink, and there doesn't seem to be any way to restore quickly this problem. So what's the body going to do? Well, it's going to tell the hypothalamus that we need to hold on to our body water. So what will happen is that glomerular filtration rate will be downregulated. We'll be making less urine per unit time, and as a result, we will make very little urine, and the urine will be extremely concentrated. This action is governed by the hypothalamus communicating with the posterior pituitary, producing the hormone ADH, anti-diuretic hormone, and this allows the body to retain as much fluid as it possibly can and keeps us relatively well hydrated until we can get to a source of food or water. Now what you're looking at down here in this little purple egg-shaped area is the connection between the hypothalamus and the posterior pituitary. That's the hypothalamus, there's the posterior pituitary, and the hormone that is produced is ADH, anti-diuretic hormone, and that again is our water retainer. Remember that diuretics are drugs that dry you out, that cause you to lose water, while antidiuretics are drugs that cause you to retain precious body fluid. Okay. And once we've made our urine, where does it go? Well, it leaves the kidney through the tip of the renal pyramids, which project into the minor calyces. From there we go to the major calyces, then to the renal pelvis, and from there to the ureter. The ureter is aligned with mucus and transitional epithelium, meaning it's both lubricated and it is a little bit distensible. It can stretch a bit. It passes under the bladder and then hooks up to the bladder at the posterior aspect. The full bladder prevents backflow. Your bladder lies directly in front of your rectum, and it can stretch to hold almost a liter of urine. It's smaller in females, usually because the uterus over the top is pressing down on it. So this is one of the reasons why pregnant mothers often report that they feel the need to urinate constantly, because of the extra weight on top of the bladder as a result of the baby. There's also 3 layers of smooth detrusor muscle, and what this does is it helps to squeeze the bladder as it fills up so that we can expel the urine. In order to expel the urine, we have to pass through a couple of different sphincters. There is an internal urethral sphincter, which is involuntary, and an external urethral sphincter that is voluntary, and so you can probably guess what muscle each is made of. The internal urethral sphincter is made up of smooth muscle, while the external urethral sphincter is made up of skeletal muscle. We control it, we tell it what to do. So there are the ureters. There are the openings that the ureters use to get into the bladder. They're called the urethral openings. Urethral openings, rather. The urethral opening is this area here, and then we pass down through the urethra and then out through the body. Now, in men, the urethra is longer than in women because it passes through the penis. And so there's three parts to a man's urethra. There is the prostatic urethra, the penile urethra, and the membranous urethra. In women, the urethra is much shorter. It still has those three parts, but because the urethra in women is so short, it makes them more prone to UTIs, urinary tract infections. So, guys, count your blessings. Because you have a set of male genitalia, your urethra is longer, and as a result, you're less likely to get an infection that works its way back into the bladder and causes all those complications. Okay, micturition is the act of urination itself, and it's triggered by autonomic reflexes. There's an internal sphincter there that responds to stretch inside the bladder, just like in the rectum. Okay, and there are also parasympathetic leads that speak to the muscles that surround the urethra. They also talk to the detrusor muscle, and they do so by causing it to contract, and this promotes urination. And we have conscious control over the external sphincter, which is made up of skeletal muscle. We tell it what to do. Now, as we age, what happens is that the kidneys will shrink, and they'll decrease in capacity. Thirst will also decrease, and this will result in increased potential for dehydration. This can result in more urinary tract infections because one of the jobs of urine is to act as a sterilant for the urethra. And if we don't urinate frequently enough, bacteria can enter the urethra and begin to set up shop, begin to grow. In males, prostate enlargement is a problem. The prostatic urethra passes through the prostate. The prostate is a large gland posterior to the male bladder. Okay? And what happens as men age is that the prostate can enlarge, and when it does, it can smash the prostatic urethra shut. And the problem there, of course, is that now there's the potential for nitrogenous waste to build up in the fluids of the body. Very, very dangerous situation. Fortunately, men can get exams to prevent these prostate enlargements from producing these negative effects. There's a couple of ways to diagnose an enlarged prostate. One is a digital exam through the rectum for men, where we palpate the prostate and look for an enlargement or perhaps nodules. And they can also use a very important test called a PSA test, which is an early detector for prostate cancer. PSA stands for prostate-specific antigen. Both of these can help stem the growth of the prostate gland and result ultimately in perhaps the prevention of an enlarged prostate or even prostate cancer. Females are more prone to the leakage of the external sphincter because it weakens, and this can result in incontinence. And in both males and females, we can experience nocturia. Well, what is nocturia? That is urination at night. Okay, something to be obviously avoided if at all possible. Okay, this brings us to the end of chapter 28. All that's left now is the final chapter of the book, and I will be joining you for that particular component.
Urine is formed by three processes in the nephron, the functional part of the kidney. In glomerular filtration, the glomerulus filters water and certain dissolved substances from the plasma of the blood. This results in increased blood pressure, which forces the plasma-like fluid from the blood into Bowman's capsule and then into the tubules. The fluid or filtrate include many positive and negative ions of many elements. The filtrate does not have any proteins or red blood cells, which are too large to pass through the capillary membrane. In tubular reabsorption, substances are transported out of the tubules and back into the blood of the peritubular capillaries. Reabsorption takes place in the proximal tubule, loop of Henle, and distal tubule. The major part of reabsorption occurs in the proximal tubule. About 15% of water is reabsorbed back into the bloodstream. The process is regulated by the hormones vasopressin and aldosterone. In tubular secretion, substances move from the plasma in the peritubular capillaries back into the filtrate in the renal tubules. The proximal tubule secretes creatinine and histamine, and the distal tubule and collecting duct secrete potassium into the filtrate. All the tubules actively secrete hydrogen ions to regulate the pH of the body fluids. The filtrate is now urine. Urine is about 95% water with a balanced urea, uric acid, amino acids, and electrolytes. The daily production is about 0.6 to 2.5 liters per day. Urine production below 30 milliliters per hour indicates possible kidney failure.